Alright, hello everyone, this is Mr. Cam Healy. He's a 65-year-old male with no known allergies. His date of birth is the 1st of the 1st, 1960, and his UR number is 246810. I'm Harriet, one of the registered nurses that has been caring for Mr. Healy today. Mr. Healy presented to the ED last night with moderate respiratory distress and exacerbation of his congestive cardiac failure. This occurred after he returned from a holiday where he accidentally missed a day's dose of his regular medication. He was transferred to the ward where we administered 40 milligrams of IV furosemide with good effect. However, during the night, Mr. Healy became quite restless and consumed 1,950 mils of fluid. Cam has experienced worsening respiratory distress. Another 40 milligrams of IV furosemide was administered at 8:30 and his other meds were administered per the medication chart. 20 minutes post-administration of the furosemide, Mr. Healy developed pulseless ventricular tachycardia and was found unresponsive. Doctor's ABCD was commenced and the MET team was called. Cam underwent 5 minutes of CPR, including 2 defibrillations. Return of spontaneous circulation was achieved. Mr. Healy does have a history of ischemic heart disease with NS3881, congestive heart failure. He had a LAD stent replacement in 2018, hypertension, hyperlipidemia, gastroesophageal reflux, osteoporosis, depression, left hearing impairment, and myopia. So currently he is GCS 15, alert and orientated, equal limb strength, BGL is 6.5, and his pupils are equal, round, and reactive to light. Respirate 20, he is experiencing shortness of breath with bilateral crackles present. He has slight use of accessory muscles, slight tracheal tug, non-productive cough present, no cyanosis observed, and his chest appears symmetrical with regular respiratory movements. His heart rate is 66, blood pressure 110 on 70. His sats are 96 on room air. S3 sounds present. Bilateral radial pulse strong but irregular. Pitting edema present on the ankles. Cap reef for less than 3 seconds. Continuous ECG monitoring has shown intermittent premature ventricular contractions. Mr. Healy has urinated in a bottle today. He's voided 300 mils of urine. His oral mucosa appears moist. We have administered normal saline at a rate of 250 mils per hour. He does have abdominal bloating, no nausea, bowels last open last night, no visual distension. He has expressed generalized tenderness across the abdomen. Normal bowel sounds are all present in the quadrants. He saw at the sternum where the CPR was performed alongside with general body aches. Cannula inserted in the left cubifoss yesterday. It's patent and flushing well. Bruising to the mid-lower half of the sternum. The area is red and tender to touch. Moderately large red blanching areas on the scapulus and hips. Mr. Healy has expressed concerns on how he is going to cope with this situation. Reassurance has been provided. He has consented to referrals for counselling, social work, and a follow-up with his GP for additional support, and his next of kin has been contacted. Continue to monitor Mr. Healy. The ECG stickers are still in situ if another ECG is needed. Oxygen to be titrated to achieve target saturation of 94 to 96. He is on room air at the moment, but just adjust accordingly. Insertion of IDC may be appropriate to accurately monitor his output. Closely monitor for post-cardiac arrest syndrome. Monitor his BGL as needed. Ensure communication is altered as needed due to his hearing loss. Analgesia may need to be explored for his pain as well. Ensure his glasses are in situ for paperwork. Follow up for referral for counselling and social work and with his GP, and keep the next of kin contacted.